Good morning or good afternoon, depending on where you're at. We will be getting ready to go in just a couple minutes here, letting everybody get in. Welcome to Virtual Nursing in Rural and Underserved Areas. Our guests today are Angel Bozard and Courtney Connors from Virtuali, and we will get going in just a minute. All right. I will continue to let people in as we go. I'm Andy Whitney, Director of Marketing and Data Analytics for Teledyne Health. For those of you that might not know, Teledyne Health is a nationwide provider of virtual care services in both acute and outpatient settings, as well as support services. And today we have with us Angel and Courtney from Virtuali. Angel, would you like to just introduce yourself?
Yes, absolutely. Thank you, Andy. We're so glad to be here today. My name's Angel Bozard. I'm the CNO of Virtuali, and I've been in healthcare for about 20 years, and building this nursing program has absolutely been the highlight of my career thus far.
And my name's Courtney Connors. I'm the nurse executive manager over here at Virtuali. I had the pleasure of starting as one of the first virtual nurses and kind of growing within the company. And my background is in orthopedic trauma. We're going to start off just telling you a little bit about our company, if that's okay, Andy.
Yeah, that sounds great. Is everybody seeing my main slide here? Perfect. All right, I will drive, and if you need me to switch slides, just let me know.
Right, thank you.
So, yep, if we go to the next slide.
Yep.
Awesome. Perfect. So we actually started back in 2017. We were born out of the Medical University of South Carolina. We started as a virtual monitoring program and watched patients for high safety risks, things like fall risk, pulling lines, altered mental status. There's an array of indications that we would watch patients for. We had some really early wins and had some early growth within the program. They said, why don't you guys go be your own company? You have such a great business plan. So in 2021, we were named Virtuali and became a private company in our own LLC. Wanted to continue to grow there. So we then the next year in 2022 opened our Orlando office. So then we expanded to Florida with our services. So we have a command center here in Charleston, South Carolina, and then another in Orlando, Florida. The following year, we didn't want to stop there. We said, why don't we start with virtual nursing? So October of 23 was when we launched our virtual nursing program. We started with about 2 rural units in rural South Carolina and 2 virtual nurses. And today we've been able to grow to about 45 nurses and over 40 units, including some pediatrics, mother, baby, and specialty units as well.
Yeah, and to add into that, we actually created an innovation center to test technology, especially with AI coming on board. We felt it was our due diligence as the end users to make sure that we can do that while still maintaining privacy of the patient and safety for the patient. So we utilize our staff as since they have done these different programs, technology, using different technology vendors for several years now. And so if you ever want to know exactly how the technology works, we're happy to help you walk through that. But we're going to get through that in a little bit. We're going to breeze by that, if you will. But if you have deeper questions, we'll have some time at the end. But then also just reach out to us. So as Courtney was saying, we started off pretty small. MUSC came to us and they said, we really want to do a virtual nurse program. How does this look? Is this something that we can do? And this was their second attempt as virtual nursing. They did try to do this within their own organization, more as a mentorship program during COVID. But they really wanted it to be more robust, and they wanted to be able to use different case studies and get different case uses, admissions, discharges, education, quality. They wanted some help with quality and those things. So as Courtney said, we started off small. We had 2 RNs, right? They came into the command center. They worked about 12 hours per day. It was about 5 to 6 days a week, not night shift, which was the first kind of feedback we've got from the nurses was, hey, we also want this on nights. It's going so well. So we did that a little bit just to make sure that our workflows were solid. So we were building those relationships with the bedside, what works well for them, what doesn't work well. And we wanted to be an extension of the team. So we spent a lot of time just with those 2 units. And then we started to grow. So they asked us to do 1 unit per month. And we said, absolutely, that sounds great. We love that. And about 2 months later, they're like, okay, this sounds great. Everybody loves it. Everybody wants it. Can you do 1 unit per week? And we said, absolutely. So we did. We scaled. So we hired nurses. We built a VRN profile. As Courtney said, she was very helpful in this. It's certain things that you don't think about with bedside nurses. They need website manner, right?
Yeah, so I think, and we'll talk about this a little bit more down the line, but I think what really separates us is identifying what makes a good virtual nurse. And there's actually an exam out there now called the Cavern exam, and it's a certified acute care virtual registered nurse, and several of our team members have this certification. It's a newer certification, but it teaches you how to be a good clinician over the web or virtually. And what Angel was saying was using webside manner. So it's bedside manner, but virtually. So in things that are included in bedside manner are looking at the patient and assessing them in a different way because you're not physically there. So I'm looking at their body language. I'm looking at their eye contact, maybe their tone of voice, and just finding nurses that are able to kind of go above and beyond and identify those things and use their critical thinking are the nurses that make great virtual nurses.
Yeah, I think that's a really great point, just because it's not easy to be at the bedside to assess patients, but it's certainly easier than it is to have, kind of like we're talking today, to see how you feel across this using technology, leveraging technology. If we have a really great story I'd love to share with everybody, and I think Courtney teased this up well, of a patient that was kind of acting in a certain way. Do you want to tell that story?
Absolutely.
Perfect.
Yeah. So we had a patient that actually worked at the facility that we were operating at. We were servicing this patient for an admission. One of our virtual nurses was talking through typical admission. Hey, I'm your virtual nurse today. I'm going to be asking you all those fun questions every time you go to the hospital. And then they got to the safety assessment of the admission, and they started asking the patient if he felt safe, if he wanted to harm himself. There was a significant, I was actually had the pleasure of being in the room and witnessing this. And the patient took a big pause and was able to confide in that virtual nurse and share that he had high risk suicide ideation. And that wasn't even something that he had shared with his spouse. So we have found that this high risk suicide ideation and just these safety indications over a virtual setting, patients are more comfortable expressing that. I don't know if it's just that in person kind of you're thinking the white coats are going to come get you if you share that, but we have found a significant increase in identifying patients that are high risk suicide.
Yeah, I completely agree with that. And that's something I think we're going to see more and more of in the mental health space, especially now where, it's the stigma is not there as much as it once was, but it's still there. And I think something about the technology and the barrier helps people become a little bit more transparent about what's really going on with them, especially to Courtney's point. This patient worked there. The last thing they want to do is tell their coworker what's really going on in their mental health space. So we were very privileged to be able to get them the help they needed immediately. Pediatrics, we find the same way. Oftentimes, unfortunately, you have kind of the readmissions and those frequent flyer pediatric patients. And what we're finding with our discharges and even our assessments, or parents were learning things they didn't know before. And we'll get into this a little bit more down the line. But that focused care is so different with the virtual nurse than it is with the bedside nurse. And it's not that the bedside nurse doesn't want to do it. It's just they don't simply have the time.
Absolutely. And one other real quick kind of story to tie into this. We also had a very similar scenario with a patient who is actually being sex trafficked. And that has happened on multiple occasions, unfortunately. And the virtual nurse is able to help provide those resources for that patient and get the right people in front of them.
Yeah. All right. So how do we do that? So Andy, if you want to go into the next slide, we'll kind of deep dive into the program a little bit.
All right.
Great. So how we integrate our approach for virtual nursing, there's a multiple pieces and pillars to this. So the role of technology, we will partner with technology vendors, and that will be a portion of how we're communicating with the client, right? So whether it's a mobile cart or in-room technology, there's kind of a few different ways to communicate with the patients, but just like you and I are talking now, we would have a two-way audio video interface to be able to communicate with the patients and perform these services. The role of the bedside and the clinical team is kind of being those program champions, really encouraging, educating their staff and their team members on the service and how it can help them in their pain points. Is it going to save them time? Is it going to save them charting? Hopefully all the above. And that ties into their objectives and outcomes. And then the role of the virtual nurse there is to help alleviate that administrative burden off of the bedside care team. They're running around with 6 patients like a chicken with their head cut off, just trying to get everyone their medication. So coming in and being able to take something off of their plate has gone a long way.
Absolutely. And I feel like, the important thing to think about here is that we are always going to be an extension of the bedside team. It should be seamless as far as the patient is concerned, that this is just a care member for me. It's not a virtual care member from a different company or an internal bedside nurse. It's simply another person here to take great care of me. And like we talked about before, kind of that focus care. We can do these admissions in its entirety and chart it without the bedside nurse having to even lift a finger about it. And then afterwards, what we do is we create a handoff. So we give that nurse kind of all over approach, what's going on with that patient, so they don't have to go through pages and pages of documentation. Do you want to talk about the handoff, Ms. Midge?
Absolutely. So what we do for our handoff is once we complete the assessment or the service that we're providing for the patient, maybe it's education, we have a comprehensive note in the chart that we will hand off and tag the bedside nurse in so they're able to see all of our findings. If there is any pertinent information when we're on service with the patient, we have the ability to call the nurse's station. We have the ability to send a direct message to the bedside team as well. The other thing that I was going to mention here is, if anyone knows anything about nurses, is that they're a little bit possessive of their patients because it is their licensed clinician. So in turn, when coming on site to these units, when I can't tell you how many times I've heard, oh my gosh, you're not AI, you're a real person. So building that trust with the team and just clinician to clinician, I think makes a huge difference as well.
That's a great point. All right, we move on to the next.
All right.
All right. So the role of the clinical and bedside teams, it's not progressing, Andy.
I think it did a little,
there we go.
Wiggle or something.
Now we're probably going to be 4 slides ahead. Who knows? Who knows what's going to happen? All right. So we want to identify the pain points that the units have, because everybody's pain point is going to be a little bit different, right? It could be everybody cares about patient safety, everybody wants our patients to be safe, but are there quality indicators that you really need to hone into? So for example, some of the med-surg have different quality indicators than maybe our mother-baby unit. Maybe the mother-baby unit's looking at surgical site infection and really having that HCAHPS jump up because they're giving the playbook of how to take care of this baby, right? So this neonate's going home with them, and typically a discharge on the floor, and I can say this because I did women's and children's for many, many years, may not be as kind of robust as we want it to be to give these moms and dads a good chance at taking this kiddo home. So we can really kind of hone into that focused care, that focused discharge. What does the patient want to learn? What do we want to teach them? And that really that starts immediately, where we all want our education and that discharge to start on a mission. With virtual care, it's probably the first time in a long time we can truly accommodate that and achieve that goal. So what we would do, and we'll get into this also, is we give you a pre-assessment tool. So we kind of walk through this with you. What are your turnover rates? What do your HCAHPS look like? What are your pain points? Is it patient care? Do you need help with that quality piece? Is it the infection side of it? Is it a safety bundle side? And then we can kind of go into that from there. And I know we want to deep dive into some real data here. So, you guys all know that the statistics of the 23% of new nurses quit their bedside within the first year, and then 50% leave within that first 2 years. All of those data and the statistics are out there. The 2 units we started with first had very high turnover rates. We're talking 70, 80%. They were in rural spaces, so it's also hard to recruit for those spaces and those hospitals. And it's not just recruiting a nurse, it's recruiting the skill set of the nurse that you need. So, as we all know, a nurse is not a nurse, is not a nurse. We all have different drivers and skill sets that make us the clinical person that we are today. And so what we found from these hospital systems is they went down to way under 20%. And the reason why is simply because the nurses had time to spend with their patients. And that's why we became clinicians. That's why I became a nurse. I'm sure many of you feel the same, is because I want to take care of my patient. I don't want them to see my back, right? When I'm charting, I want them to see my face. I want them to feel my hands on their bodies and make sure that they know that I am there for them and I'm taking care of them. And I'm taking good quality care from them. I'm not distracted. And I have these things to do. I can take my lunch break also as a clinician. That's important. And, make sure I get out on time to spend time with my family. I don't want to be charting till 9 o'clock at night and missing dinner, right? So all of those things kind of go into the results we are seeing all across the board from all of the hospitals we serve. They also use us as a recruiting tool so they can say, look, we have this resource for you. You don't have to do every admission. You don't have to do every discharge. And what you find is that now the nurses are okay with discharging that patient a little earlier because somebody else is going to take the administrative burden off doing that admission for them. And like I said earlier, we chart it all so they can simply just have it out of their mind and know that it's taken care of.
I think one thing we shouldn't underestimate is the mentorship role that a virtual nurse can play as well. You spoke a little bit to the rural dilemma of retention and recruitment of nurses. And man, during COVID, we saw so many experienced nurses retire because it was just like, yep, I'm done now. And
Right.
so the average age of a nurse in a rural facility is way younger than it used to be. So the role you guys can play in that mentorship role can't be underestimated.
I completely agree with you. And that's something I'm so passionate about. And once again, back to that VRN profile, that's something that we hone in on so much is, are you a nurse's nurse? Do you want to take care of the nurses just as much as you want to take care of the patients? Because if not, this is not going to work. We want to keep the bedside nurses at the bedside, keep them happy, keep them engaged, keep them coming back, and not leaving our field, right? So how do we do that? We build those relationships, and now they know, like, Courtney's here to take care of me today. Like, she's going to take my admission. She's going to do this education. She takes this burden from me, and it's so very important that we're able to do that. But also, what if you haven't done a procedure in a while, or you haven't given a med before, this particular type of med? And it's, no judgment zone. You just, call a friend, if you will, and just say, hey, virtual nurse, can you just stay at the bedside while I walk through this? And we're there for it. Absolutely. And, at the end, that not only helps the nurses, but it helps the patients, right? So that's, obviously you guys can tell we're very passionate about
yes.
that.
And that's what I was just going to say. Not only does it help bolster that new nurse's skills, but it's going to help the patient outcomes because we were maybe able to catch a potential error.
Yeah. We also were finding, which I feel is interesting, I'm just going to kind of take a landing point here for just a second because this was a meeting I had yesterday, that length of stay, there's a new article out about this, and I think it's really fascinating. Length of stay has been reduced by about 7% because of the quality admission that's being done. We always thought it was more of the discharge side, right? So we go in there and we do a great med rec and we give them all the information about their new disease process or whatever the case is. But what we're finding now is that if we set them up for success, if we set the patient up to begin with, that first time they come in and we go through this complete admission with them and they are engaged and we are engaged and we're focused in on it, that actually the length of stay decreases because of the fact that we're not kind of backtracking medical care, right? We're not learning 3 days into the admission, oh, you haven't actually taken this medication for 6 months. So those are kind of things that we're unpacking now, which I find is completely fascinating.
That's great.
Yeah. Next slide. Yes. We'll go into the implementation process.
All right. And with our implementation process, what Angel mentioned before, we use that pre-work assessment tool to identify what are your pain points at your facility or on your unit. Then we'll go and walk the unit. We're going to go get a visual of the space that we'll be working and operating in, and help determine technology as well. What we'll do, especially units that are specialty units or maybe pediatric units. We recently had a mother baby unit. We spent a lot of time going on site, shadowing the nurses, shadowing their admission process, their discharge process, and even their unit rounds. The reason is because we want to be that extension of their team. We want to operate exactly like they operate, so you won't even tell if it's a virtual nurse or a bedside nurse. And understanding the unit's unique initiatives. One of the units that we work with is doing an initiative now on what's the most important thing to the patient. So identifying things like that are going to help the bedside team as well as the virtual nurse care better for the patients. After, we're going to have a post assessment to discuss and then have regular follow-ups. We do quarterly, monthly. We'll kind of go with whatever the unit leader prefers, a cadence of touch points. And with compliance considerations, we'll do all the integration into the hospital system so we can work with the EHRs that the hospital systems use and work with their regulatory compliance and quality department to make sure that we're in line with all of those.
Yeah, it's a great point. And I think communication is another thing that we need to kind of like take a beat to speak about. Oftentimes we use a secure Epic chat, which works for some hospitals. If you didn't have Epic, then we can fold into your communication. So that is something kind of Courtney talked about earlier, calling that nurse if something was kind of going on, that there's different ways to communicate. We just want to make sure that it's such a great collaboration between the bedside and the virtual nurse that there's nothing that falls through the gaps, right?
We know nurses don't have, if they have 6 patients, they don't have the time to be sitting, staring at their computer, waiting for a virtual nurse's message. We had a scenario where a patient we were admitting had an active seizure. We were able to then make a phone call to the bedside to immediately get assistance. And we also were able to use that mentor piece of it as well. And they didn't have any seizure pads to protect that patient on the bed. So we gently reminded them, hey, just so the patient doesn't hit their head or get injured during this, do you mind putting some pads on? So it was a win-win in that sense.
Right.
Do you want to go to the next slide? Yeah, there we go.
Yep.
And starting to read our mind now.
Yeah. As far as the program build, so just really identifying the right people to build this workflow for the virtual nurses. We're going to do a pre-data analysis and prioritize, again, what the unit's needs and initiatives are. Look at what use cases we can do and structure a pilot and build out an expansion plan. So as she mentioned earlier, we would take on a unit a month and then it became a unit a week. So just coming to an agreement of how often and how frequent we can scale. As far as the KPIs and discovery, we will define what it is for the virtual nurse to help improve these scores, and maybe different assessments or different portions of the admission or different education components, kind of whatever we need to do to help improve that.
100%. And oftentimes what we find is we get a champion that has either used virtual care before or is very invested in it, that's on the floor. I will, be very transparent. Our first unit when we came in, and once again, it was a rural unit, rural hospital unit, but they were like, what is this? Are you trying to take my job? That's a common question we get, right? Or are you trying to replace me? Are you trying to increase my ratios? Is this going to make more on me as a nurse because I already have enough, right? So we feel like for years now, we've kind of put more and more on the bedside nurse, with all of the documentation. I feel like I've been a nurse long enough. I carried a lantern and documented on a stone, but at the end of the day, we have done that. We've had to, right? We have all these quality measures that we need to put in, and there's so many governing bodies that we just keep piling on and piling on. And then, so this is the first time we can truly make an impact and say, look, this is a net new resource we're giving you to make sure we lift this burden from you. So at the end of the day, you're not upset to come into work and you're happy to be here, and everybody feels that, right? So kind of going back on the KPIs of what works best for you, what you're trying to identify, will also help you create a baseline so that as we do these touch points, then we can say, look, hey, your turnover was 70% before. We've used this as a recruiting tool. The nurses are happier. This is showing in patient satisfaction. This is showing in nurse satisfaction scores. And then, we can kind of expand from there. So right now, if the nurses feel most comfortable just doing admissions and discharges and us lifting that burden, they'll become more virtual care as our life raft. So, and that's kind of what we're seeing now is, everybody's coming in as like pharmacies coming in. Can you help us with med rec? IDs coming in. Can you help us with this penicillin? Case management wants it. So, it's very exciting because the word of mouth has really gotten out there to where it's like, we need this at every ancillary department needs it. Every unit needs it. We can kind of modify this to our needs on the unit.
Next slide, please. All right. So as far as staffing, we have a few different staffing models, and we'll kind of, again, go with those needs of the unit. So at a 12-hour shift, an average virtual nurse will see about 7 to 10 patients, and they will service several units throughout the facility. We have created as well a flex position. So for those really, really busy hours, those late discharges and those admissions coming up to the floor, it all seems to be after 3 o'clock. So during that time, we're able to help bring on some additional staff to offload that busy queue. And then we have a lead. We use sort of in simultaneously to a charge nurse. We have a lead nurse that is kind of our air traffic control. So they bring in all of the requests and delegate each request to the team or fleet of virtual nurses that we work with each day. And then there's a few different models of virtual nursing. There's that ADT model, so that admission, discharge, transfer model, typically one virtual nurse to about 40 beds. And they're doing those administrative admissions, discharges, transfers, maybe some education here and there. Really associated with all of that administration, like I said, and closer to a 1 to 30 ratio there. As far as the care partner model, what we kind of highlighted earlier on, is really being an extension of that bedside team. It's a smaller ratio of 1 to 20, performing like services like admission, discharge, and transfers, but with the addition of really honing in on things like education. We can add dual medication sign off, maybe rapid response or code documentation, and other documentation, 2RN skin checks, and things of that nature, to really be a care partner and be part of their team day to day.
Absolutely. And I think, Andy, you touched on this earlier, that mentorship is just invaluable. Like we
Yep.
have so many novice nurses, especially at nights, and that's where they need that phone a friend option, and just somebody that's there, another set of eyes. And what we find is that, especially in critical access hospitals, that there are several nurses sometimes there, but it's just a matter of skill set. So maybe they haven't seen something before. Well, we have a fleet of nurses. So you can go on and you will have an ICU nurse or a labor and delivery nurse, or whatever suits that need, an ER nurse that can say, yes, okay, I understand that this is what's going on with the patient now. Those are the next steps, and maybe even until the doctor gets in, or if they're having to transfer out, hopefully we're able to stop that transfer and keep the patient in the hospital, because that's our goal. But if the end case is they need to transfer out, they're stable when transport team gets there. So we kind of work in tandem to make sure that that patient has the safest care possible. And then quality. We do so much with quality, and that really depends on those KPIs as well, and setting you up for success there. But as soon as the nurses come on, the virtual nurse comes on, they instantly do a safety bundle with the patient. It's just second nature for them. Does the patient have bed rails up? Do they have their socks on? How do they look? It's just a matter, within moments, they are going ahead and doing that visual safety bundle to make sure that we're set up for success there.
Absolutely. Next slide, please.
All right, roll of technology. And this is where we take a deep breath.
This part is super imperative. It kind of determines what we're able to do.
Absolutely, 100%. So I would say, technology agnostic to a point, right? So our job as the end users is to make sure we vet the technology and we know it's going to work and work well for you and the patient. It's a little bit different with virtual nursing because it's episodic. Just like if somehow this webinar dropped right now, we would all just get back on and it would be a little bit of a pain point, but we would be okay. Continuous monitoring with the sitting, it's a little bit different, but we're here, and what we do is we do a scorecard and we can kind of tell you what's going on. Because as we know, AI is on board, right? So there are so many companies out there with all the shiny tools of, we can do this, but is it really being done anywhere? And, you pointed this out, we're very protective of our patients. So we want to make sure that they're not suffering because we want to test something. AI is something we're very excited about. I think ambient listen is going to be amazing. But if you've ever sent a text message via Siri and it didn't come out the way you kind of expected, which hopefully has only happened to me, although I don't feel like I'm alone in this, then you don't want that in your chart, right? So you don't want something that maybe a visitor said they have going on to end up in your chart because, the environment said it was true. So we do have a scorecard to help out with that and to kind of lend some guidance.
Mm-hmm.
But also it really kind of depends on what you're looking to do. We certainly don't want to rip and replace. Technology is expensive.
Right.
And so what is this going to look like for the long haul? Just because you put it in today, you want it to last the next couple of years and not be antiquated by the time that you spend this money and put this in. And I think there's more to this. Like, there we go.
I think there's a couple more points there. Yeah.
Yeah. So we lent heavily on our culture here and our core values. And I feel like when you choose your technology and your technology partners, that's something you want to be very mindful of because it is a huge investment and it is a partnership. Obviously, we all work together as partners, but that technology has to work in that triad as well. So it's mindful just to kind of be thoughtful of where you want to be in the future. Give it the 5-year plan, not what we need for this very moment. There are certain things in virtual nursing you cannot do with certain technology. So for example, if hourly rounding is exceptionally important to you, then you don't want to use a cart, right? It doesn't make much sense for people to take a cart from room to room to do hourly rounding. It would make more sense for that in-room technology. So it's just something to be kind of mindful of there.
Yep. And I think culture is really key there too, that you mentioned. We all want to partner with organizations that match our values. I think that's what we really like so much about Virtual Ally is we really mesh well together.
Completely agreed. I think, yep, we kind of went through all of that.
Yep.
I don't know exactly why they're piecemealing today, but all right, the virtual nurse.
Awesome. And if you want to just click, there's a few more.
Yeah, I guess it stops as enable more. Yep.
Awesome. Perfect. So the virtual nurse, how it started is kind of wanted to start the workflows, enable rapid expansion and adoption, which turns into yield measurable outcomes and faster across your core metrics.
Yeah. So, as they come to us and ask us about virtual nursing, what they really wanted was support and help. They know their turnover was becoming exceptionally high after COVID. We talked about this earlier, that mass exodus, right? So nurses were leaving by the droves. And how can we not only keep the bedside nurses there, but recruit others and support the ones that we have? As you pointed out, we have a lot of nurses that are on retirement age that simply just can't stay at the bedside anymore because of the stress of it, right? So how do we reduce that stress? And how do we standardize our workflows and make sure the patient is safe together and become an extension of that team? And that is so important. I don't think I can really lean on that enough, but if the bedside nurses for any way, shape, or form don't want to use virtual care, they're not going to, and your program's going to fail, regardless if it's an in-house program or a purchased labor. We have to have that insight from them. But once again, with purchase labor, you're able to scale a little faster probably than you are if you just try a in-home solution. And the reason for that is probably your resources are already a little bit tapped out, right? So if you only have a certain pool of nurses to choose from, it always sounds great when you're like, we'll give you 2 days on the floor and 1 day virtual nursing. But sometimes that can become a little bit confusing to them of who gets to do that. And it's kind of harder to scale in that aspect.
It can also cause some conflict internally as well. If say it's up to the manager's discretion of who's going to be the virtual nurse for today, if it's an internal program. If she chooses Sally Monday, Tuesday, and Wednesday when Sally's working, Nurse Jess is going to be like, well, why didn't you pick me? She gets to go do all the fun work. Now I have to go clean up all these patients my 3 days that I was on. So I think what's really unique about our program as well is that we have a unique pool of nurses with all different skill sets. So we have ED nurses, IC nurses, pediatric nurses. So we're able to really find, if anyone knows nurses, there's different types of nurses out there. So we're able to kind of align with these different bedside nurses and really figure out what it is that their needs are and what helps them the most.
Yep, that's perfect. Absolutely. And I think we only have about 10 minutes left. So if you want to skip to maybe that last, we can go through this for a smidge and then the last slide, just discussing our outcomes. I feel like, I think it's one more. Next one, because we can, here we go. Because I want to make sure you guys have time for questions if you have them. We kind of touched on this a little bit earlier, but you can see that, it's so much more than this. And our data points are truly coming out now. We've actually submitted a survey to the bedside nurses about how it's working and it's working exceptionally well. For the first time, they feel like there's some reprieve in their day-to-day. But we look at the timeliness of discharge. You can see there's about a 51% improvement there. Something we didn't put on here is the courtesy of the admission nurse. And it's not that our bedside team are not courteous. They just simply cannot be focused in because, there's a doctor waiting and they have they have 83 meds to give. So we just want to make sure that, when the patients see us, the first impression they have of that unit with the virtual nurse is that we're here to take care of them and it's a team effort. So I think for the next maybe 9 minutes, we open it up for questions. Is that fair, Andy?
Yeah, that sounds great. If anybody has any questions, please post them in the Q&A section or the chat section. I'll kind of keep track of those and go from there. But I think while we wait, specifically, I think some of these outcomes are awesome. They look really, really impressive that you guys have made a difference in some of these communities. I think, speak a little specifically maybe of some stuff you learned jumping into some of the rural stuff. Your roots are kind of in rural, which is great. So what did you learn kind of entering into virtual nursing in a rural facility?
Yeah, I think that's a great point. I think it's a little bit different than our tertiary care centers, right? They don't have the same resource. They don't have the residents that are there to help and the multitude of people. So what we found is we had to grow our fleet and our skill set of nurses to make sure that there's somebody always available depending on what's going on with that patient. I think that was a first learning curve. And then second, our very first units we brought on board, we realized it was so incredibly important to build those relationships with the bedside nurse. I think in our minds, they were just going to have this like celebratory, woohoo, virtual care is here to save us. But at the end of the day, they did have a lot of fears. And we went on site and we addressed those fears. To Courtney's point earlier, they could actually see us, that we're real people, we're real nurses. We've been at the bedside. And our goal is to help them, right? We're nurses. We want to take care of them. And I think that was something that we didn't even realize was going to be a huge concern for them. But just going to their staff meetings, going to shared governance, walking through what we can do, what we can't do, and where we need to lean on them, really kind of improve those relationships pretty quickly.
Yeah.
I think with the rural spaces as well, as ratios are higher oftentimes. So that's another thing to be mindful of. And with the lack of resources, the communication amongst the teams can look very differently. So just making sure that that's probably one of the most important things, right, is communication. So making sure there's a streamlined way of communicating with the bedside.
Yep. How do you overcome maybe resistance? I'm thinking, I've been doing this 10-ish years now, and there always seems to be, when we roll this out to a facility, one of our services, there might be one nurse in the background that's kind of sitting there like this, a little skeptical. How do
Yeah.
you work with those folks and overcome, maybe skepticism or just fear?
Yeah, I think first thing you need to do is see where their pain point occurs, right? So what is the concern here? Is it that you don't want to do something new? Is it you worry about your position? And then you just kind of walk them through the program. Let them see both sides of what the virtual nurse does, introduce them to some of our team members as something that we get quite a bit. And I know people are scared right now because of so much AI and chatbots and everything, that they worry that their patients are not going to be taken care of. And that's what I would worry about too, right? As a bedside nurse, and I was a NICU nurse for many years, if you told me some other nurse was going to come in and look at my baby, my neonate, I'm like, ooh, I'm not really sure about this. I don't even know that I want my coworkers doing that. This is my baby. This is
Yep.
They need to see that we do have the skill set. We're there to help them. And at the end of the day, working together collaboratively makes this better for the patient.
I think having that nurse to nurse connection too makes a huge difference.
Yeah.
Nurses really respect other nurses.
Yep.
So even giving that person maybe the FaceTime of going in and saying, hey, I was one of you, and I'm just here to help you.
Yep.
So I think just making that connection, bringing it down to their level instead of someone like a CFO or a CNO coming in, here's a new thing that we showed you, saying, I was in your shoes and I'm here to help you, I think goes a long way.
I agree.
Yep. I think one of the keys to, long-term sustainability for rural hospitals is being able to kind of increase the complexity of the patients that they're seeing and keeping there and reducing the number of folks they transfer. So talk a little bit about, helping those rural nurses get more comfort level with maybe more complicated patients than they've been accustomed to treating.
Yeah, I think that it's so important. We actually visited critical access hospital not that long ago, and they had 5 nurses on the floor there, but they have a ED that they were taking care of, an ICU they were taking care of. One of the nurses was an LPN, a very new LPN. So when we're talking about that mentorship piece, we're also talking about nurse education, right? So when they come to us and I haven't done this procedure before, and we walk that through, then that makes them more comfortable next time they have to do it, or next time they might call us again. But maybe by that third time they do it, they're more acclimated, and then they're going to teach somebody to do that, right? And then kind of the same thing if maybe they haven't seen a pediatric patient do XYZ. Every time we interact with the patient, that nurse is learning something new. And because I said earlier, we have this fleet of nurses with this multitude of skill set, they're able to kind of pull in those expertise. It's so much easier than, I've never been an ICU nurse, but I've got this patient now that's rolling through the ED that this is going on. And you can kind of see how you would triage that patient and make sure that they get to the level of care they need, or hopefully able to stay in the hospital once we can stabilize them.
Yeah.
Because that's the goal.
That is the goal. And I think that's another place where we align so well, is really being able to give those nurses the tools to keep more complex patients, raise the acuity level of patients that they have in that facility, and at the end of the day, help their hospital, not just survive, but thrive.
Absolutely. That's a great point.
So,
and that also ties into identifying what makes a good virtual nurse. Are they someone that is a team player and wants to help and mentor?
Exactly. Great.
All right.
Well, this has been great. Thank you so much for your time today. For those that have attended, the recording will be available. You should get an email when that's ready. And I will also be posting that later on the Teledyne website. But this has been really great having you guys here today. Thank you, Angel, Courtney, for sharing some of your experiences with us. And we look forward to reaching out and learning more sometime.
Thank you so much, Andy.
All right.
Appreciate you guys'
Thank you,
time and
everybody.
attention. Take care.
Bye.